Hi, my name is María José Benalcazar, and I'm going to talk about Polyhydramnios, transient antenatal Bartters Syndrome and MAGED2 mutations. Definition: Polyhydramnios is the excessive accumulation of amniotic fluid, transient antenatal Bartters syndrome, known as the impermanent Bartters syndrome, a rare inherited defect in the thick ascending lip to the loop of Henle during pregnancy. These pathologies are commonly caused by a mutation of the protein coding gene MAGED2.
Syndrome is a rare inherited defect in the thick ascending limb of the loop of Henle. It is characterized by low potassium levels, increased blood pH, and normal to low blood pressure. There are two types of Bartters syndrome, neonatal and classic. A closely associated disorder, Gitelman syndrome, is milder than both subtypes of Bartters syndrome. Features: in 90% of cases, neonatal Bartters syndrome is seen between 24 and 30 weeks of gestation with excess amniotic fluid. After birth, the infant is seen to urinate and drink excessively. Life-threatening dehydration may result if the infant does not receive adequate fluids. About 85% of infants dispose of excess amounts of calcium in the urine and kidneys, which may lead to kidney stones. In rare occasions, the infant may progress to renal failure. Patients with classic Bartters syndrome may have symptoms in the first 2 years of life, but they are usually diagnosed at school age or later. Like infants with the neonatal subtype, patients with classic Bartters syndrome also have polyuria, polydipsia, and a tendency to dehydration, but normal or just slightly increased urinary calcium excretion without the tendency to develop kidney stones. These patients also have vomiting and growth retardation. Kidney function is also normal if the disease is treated, but occasionally patients proceed to end-stage renal failure. Bartters syndrome consists of hypokalemia, alkalosis, normal to low blood pressures, and elevated plasma renin and aldosterone. Numerous causes of this syndrome probably exist. Diagnostic pointers include high urinary potassium and chloride despite low serum values, increased plasma renin, hyperplasia of the juxtaglomerular apparatus on renal biopsy, and careful exclusion of diuretic abuse. Excess production of renal prostaglandins is often found. Magnesium wasting may also occur. Diagnosis: people suffering from Bartters syndrome present symptoms that are identical to those of patients who are on loop diuretics like furosemide. The clinical findings characteristic of Bartters syndrome are hypokalemia, metabolic alkalosis, and normal to low blood pressure. These findings may also be caused by chronic vomiting. These patients will have low urine chloride levels. Abuse of diuretic medications: the physician must screen urine for multiple diuretics before diagnosis is made. Magnesium deficiency and calcium deficiency: these patients will also have low serum and urine magnesium and calcium. Patients with Bartters syndrome may also have elevated renin and aldosterone levels. Prenatal Bartters syndrome can be associated with polyhydramnios. Pathophysiology: Bartters syndrome is caused by mutations of genes encoding proteins that transport ions across renal cells in the thick ascending limb of the nephron. Bartter and Gitelman syndromes can be divided into different subtypes based on the genes involved. Treatment: while patients should be encouraged to include liberal amounts of sodium and potassium in their diet, potassium supplements are usually required, and spironolactone is also used to reduce potassium loss. Non-steroidal anti-inflammatory drugs can be used as well, and are particularly helpful in patients with neonatal Bartters syndrome. Angiotensin-converting enzyme inhibitors can also be used. Prognosis: the limited prognostic information available suggests that early diagnosis and appropriate treatment of infants and young children with classic Bartters syndrome may improve growth and perhaps neurointellectual development. On the other hand, sustained hypokalemia and hyperinemia can cause progressive tubulointerstitial nephritis, resulting in end-stage renal disease. With early treatment of the electrolyte imbalances, the prognosis for patients with classic Bartter syndrome is good. History: the condition is named after Dr. Frederick Bartter, who, along with Dr. Pasita Prunov, first described it in 1960 and in more patients in 1962. Related conditions: Bartter and Gitelman syndromes are both characterized by hypokalemia, hypermagnesemia, normal to low blood pressure, and hypochloremic metabolic alkalosis. However, Bartter syndrome is also characterized by high renin, high aldosterone, hypercalciuria, and an abnormal NAR ± K ± 2 centiliters transporter in the thick ascending limb of the loop of Hien. Gitelman syndrome causes hypercalciuria and is due to an abnormal thiazide transporter in the distal segment. Pseudo-Bartter unregistered trademark S syndrome is a syndrome of similar presentation as Bartter syndrome but without any of its characteristic genetic defects. Pseudo-Bartter unregistered trademark S syndrome has been seen in cystic fibrosis, as well as in excessive use of laxatives. References. External links: the Bartter site.
Application in medicine. The study tries to determine the genetic basis of this disorder, provide information to the pathology that suffers. The information can be used to treat the mother and time by detecting the mutation on the sequencing of DNA.
Babies in the uterus are surrounded by amniotic fluid. However, some women do develop increased amounts of this amniotic fluid as the pregnancy progresses. And at around 30 weeks, some women are found to have excessive amounts of amniotic fluid around the baby, and this is called polyhydramnios. Now, it might be felt by the midwife on palpation, or it might be diagnosed on scan. But certainly, depending on what the findings are, would determine the management from then on. In the majority of cases, polyhydramnios will resolve itself and the woman goes on to have a perfectly normal, healthy baby. But polyhydramnios in some cases can show an indication that there is a problem with the baby. So it might be that the woman is sent for further tests. She might need to have an amniocentesis. The mode of delivery again might come into question depending on what the findings are. With polyhydramnios, because of the amount of fluid that is circulating round, there can be a risk of the baby's cord coming down in front of the baby's head if the waters break. So again, it would be very much on an individual basis how it would be managed.
Pros. The treatment will help the patient their quality of life. The antenatal Bartters syndrome is transient, meaning is temporary.
I am Dr. Suhasini Inamdar. I am obstetrician and gynecologist from St. Philomena's Hospital and Cloud9 Old Airport Road, Bangalore, India. Amniotic Fluid Index or AFI is measurement of amniotic fluid during pregnancy in the womb. It is a measurement which is taken by sonologist and it is given usually in millimeters or centimeters. The normal range of amniotic fluid index or AFI is 8 to 18 centimeters. And it is measured by a sonologist when you go for your checkups, and this is a very good indicator of fetal well-being and a healthy pregnancy. The AFI is measured by dividing your uterus into 4 imaginary quadrants. In each quadrant, then a clear pocket of amniotic fluid is seen and measured vertically. What I mean by clear amniotic fluid pocket is there should not be any fetal parts or umbilical cord in that area. So we get whatever is the fluid as a correct measurement. Then all these 4 measurements are added on and the sum is given to you as amniotic fluid index. Now there are 2 ways of denoting these indexes. One is you can be just told the measurement in centimeters saying that it is 5, 6, 10 or 12, or you are given some charts in which there are percentiles, and in between the percentiles your amniotic fluid index should fall. Anything below 5 percentile, 5th percentile or 5 centimeter is not good. Between 8 and 18 is good, which is called as normal AFI. Below 8 centimeter we call it as oligoamnios, and above 18 centimeter, when the fluid indices are around about 20 to 21, we call it as polyamnios. The reasons for hydro and polyamnios and oligoamnios are very different. In oligoamnios, there are some factors which are related to mother, as in improper nutrition, strenuous lifestyle, hypertension during pregnancy. Some are placental indications which are responsible for oligoamnios, like poor functioning of placenta, and some are fetal indications which can be improper formation of urine in fetal body because of lack of one kidney or poor functioning of one kidney, or some blockage in the urinary bladder of the fetus. So these are the reasons what we normally get when we see oligoamnios. Another biggest reason is premature rupture of membranes, which we call as PROM. So these are the reasons for oligoamnios. Normally gestational diabetes in mother is one of the major reasons for polyamnios. So when you go for your routine checkups with your gynecologist and obstetrician, they see into AFI and feel very comfortable when it falls in a normal range. Otherwise, they'll advise you what is to be done to keep it under normal range and keep it in a safe limit.
Cons. The treatment doesn't include the solution of the gene mutation. Just male babies have the risk to have these pathologies. Issues applied in Ecuador. The incidence is low. Cases are very rare to find among the Ecuadorian population. Also, the treatment can be the best because hospitals don't have the necessary equipment or medicine. Conclusion. In conclusion, this study gives the doctors more information about how to detect and treat pregnancy with these complications as Polyhydramnios and Bartters Syndrome. Thank you for watching. This is it.